diabetes. So over next 20 minutes, I am going to give you an insight why we are talking now about inflammation and how it is related with the diabetes. If we see some of the recent publication, inflammation has been linked to diabetes, metabolic syndrome, atherosclerotic disease, including cardiovascular disease and prediabetes. So in today's lecture, I am going to focus on diabetes. And I have framed some questions. Why we are saying actually inflammation causes type 2 diabetes? Now for that, first we have to understand what do we actually mean by inflammation. When we talk of inflammation, we means in a common sense, fighting against infection. Now there is a difference between fighting against infection and inflammation which get activated in chronic diseases. Now if we see our body, when we come on this earth, we come with a type of immunity which is known as innate immunity. And innate immunity is served by macrophages, Kupffer cells and endothelial cells. There is another type of immunity which is known as adaptive immunity, which is cell mediated and acquired, and which is acquired later on to fight against infections. So there is a difference between two types of immunity. One is innate immunity, one is adaptive immunity. Now, what are the components of innate immunity? Even when we are in stress, whatever type of stress, it may be exam stress, it may be marriage stress, it may be personal stress, even a simple stress at the level of brain will cause activation of macrophages, which is a component of innate immunity. And over macrophages, there are presence of certain receptors like toll-like receptor for advanced glycation end product, and they get activated in presence of stress, and when they get activated, there is release of inflammatory cytokines like TNF-alpha, IL-6. Now these inflammatory cytokines go back at the level of brain, will result in increased secretion of catecholamine and ACTH. Now both these are stress hormones. They prepare a human being to survive against the stress. So there is secretion of catecholamine and ACTH. Also, the sickness behavior which one develop under stress is related to cytokines. These cytokines also goes at the level of liver and will result in secretion of number of acute phase reactants. So this is our innate immunity. Now what is happening that in a patient on a genetic background, if there is a defect in diet, patient is becoming obese, he is smoking, he is physically inactive, all these things will result in activation of innate immunity. Now because of activation of innate immunity, as I have explained you, there is secretion of cytokines which will result or which will predispose a genetically predisposed individual to develop type 2 diabetes, insulin resistance and early cardiovascular disease. So friends, in a normal health, with an optimal nutrition, we have normal immune function. When we have undernutrition, which is again a big problem in our country, there is an immune suppression and there is an increased susceptibility to infections. That's what we teaches to our students who are learning pediatrics. And when we have overnutrition, obesity, there is activation of innate immunity, which is different from acquired immunity. And this activation of innate immunity predisposes you to develop diabetes, cardiovascular disease, and number of other lifestyle disorders. So there are two components, macrophages and adipocytes, and each has their specific functions, but they can subserve the function of other component. In obesity, obese tissue become overloaded with fat, and there is relative ischemia around inside the adipose tissue. The result is release of inflammatory cytokines. At the same time, in obesity, macrophages start accumulating fat. They become foam cell. They become unstable, and they predisposes to atherosclerosis. And there are certain protective like PPAR gamma, lipoid X receptor. They prevent against this damage. So we have two phenotypes. The Indians are typically thin fat phenotype. Just focus on these two cylinders. There is a vertical cylinder and there is a horizontal cylinder. The horizontal cylinder is our fat mass. Now fat mass is actually your metabolic load. To fight this metabolic load, you need metabolic capacity, which is your lean muscle mass. Now if you see Indian phenotype or Asian phenotype, For same metabolic load as compared to our Caucasian counterparts, we have less metabolic capacity. Now, when you are having less metabolic capacity and you put up more body weight, you become more physically inactive. It means you are putting up more metabolic load, then you are destined to develop diabetes and metabolic disorder. This is a classical paradox which has been shown by many speakers, including international speakers, Dr. Yudkin and Dr. Yajnik. Now, if you see the body fat disturbance, they have equal BMI, 22, equal BMI. But if you calculate the body fat, it is 9% in Dr. Yudkin and it is 21% in Dr. Yajnik. So, at the same BMI, there is a huge difference in body fat of people of Indian and Asian origin, which puts us at increased inflammation. So friends, because of this concept, we are predisposed to develop this, and it is not only a theoretical concept, there are a number of loss of function and gain of function. Animal models, I am not going to discuss and bore you, we'll soon come to the clinical aspect, which have actually shown that there is a definite role of inflammation in chronic lifestyle disorders. Apart from, so we know about eight different defects given by De Fronzo. So now there is a ninth defect, which is inflammation, which become activated in diabetes, and it is not only disease, it is also driving your complications, your microvascular complications. So knowing this in brief, that inflammation is important, it gets activated and it is driving the development of diabetes and cardiovascular disease. When we know there is inflammation, then the next question as a clinician is how to measure it. If there is a problem, we should have some surrogate markers. Then only we can solve that problem to find out this inflammation is going down. So what are surrogate markers of inflammation? There is a whole list of markers which are available and which has been researched, and there are a number of papers. And out of all these, WBC and HSCRP, they are simple, easily available, probably they can be performed. Some of the studies have shown that if you see WBC, if you have a WBC, if a person is having a WBC count of more than 6,900, that individual has 52% more chances of development of diabetes. Similarly, for HSCRP, if you see for every tertile increase in HSCRP, irrespective of gender, whether you are men or whether you are women, you are predisposed to develop diabetes. And if you compare a euglycemic individual with pre-diabetes and diabetes, as you see clearly, with change in glucose tolerance, the HSCRP kept on increasing. See the bar of more than 0.3, and this is the bar of more than 0.3. So definitely inflammation is coming into play. And these are number of studies. This is a forest plot graph, and as you see in this forest plot graph carefully, overall it has been shown that inflammation plays a role in development of diabetes. Apart from this inflammatory markers, adiponectin, which is a surrogate marker for insulin resistance, it is surprisingly drastically low in Asian population. So this is a meta-analysis which have shown the strength of association between various inflammatory markers. So now we are thinking probably we have found the answer. The answer is no. We have some problems and we have some uncertainties. The first question is, it's like chicken and egg story. Which comes first? Chicken come first or egg come first? Nobody on this earth actually knows the answer. So whether inflammation become a primary or secondary phenomena, this is a debatable thing, which we can debate for a number of hours, but we does not have a clear explanation. Does treatment of primary disease reduces inflammation, or do we need additional intervention? And there are a number of other inflammatory disorders like rheumatoid arthritis, which is one of the very common disease seen by our rheumatologist colleague. What is the prevalence of diabetes? That's an inflammatory disorder. We have done some of our work where we have taken patients of rheumatoid arthritis who were not receiving any glucocorticoid, and they were having rheumatoid arthritis for more than 1 year. Then we have also taken a control group, normal, healthy population. And both control and rheumatoid arthritis patients were subjected to oral glucose tolerance test and HbA1c. And what we have found that people who are having rheumatoid arthritis active disease and they were receiving methotrexate, infliximab and other therapies and no glucocorticoids, surprisingly they have an increased prevalence of new onset dysglycemia, which means It is not a theoretical concept, it's practically there, but actually we are not looking at it because we are not discussing at it, and eyes does not see what mind does not know. So this is a real problem. Now how to tackle it? The next question is how to tackle it. Now we know there is a problem, it can be measured. The next question is how to tackle it. For that, if you go back to the literature and if you go back to the pathophysiology of diabetes, there are a number of drugs which has been tried. If we see, there are drugs which has been given for nuclear factor kappa B, salsalate. There are drugs which are anti-TNF alpha, means acting against TNF alpha. There are drugs against IL-6 and there are drugs against IL-1 beta. So the literature is full of information. And if we see salsalate, this is a tinsel trial, popularly known by this name, where it has been shown that by giving salsalate, which is a prodrug for salicylate, there is an improvement in insulin sensitivity, there is improvement in HbA1c, but unfortunately there are some unwarranted cardiorenal signals. For that, salsalate has not been developed as a drug for management of inflammation in diabetes. Then anakinra was tried, which is actually human interleukin-1 receptor antagonist. Again, as you see, there is only a modest HbA1c reduction, drug required to be given injectably, and there are immune-mediated side effects. So again, not developed further. Canakinumab, again IL-1 blockers, so same problem, very modest reduction of HbA1c, injectable, immune-mediated side effects, so not tried. In recent past, there has been interest for a molecule which has been tried for years for management of rheumatoid arthritis and its anti-inflammatory potency in diabetes. And if you see some of the literature, HSCRP use, hydroxychloroquine use has been associated with reduction of HSCRP as well as drastic improvement in HbA1c. And the initial studies, actually small studies, have actually come from the West. But it is actually one of the Indian pharmaceutical company which has taken a step to develop it as an anti-diabetic agent. How hydroxychloroquine is effective in management of diabetes? It is acting at number of steps. Specifically, we should target that it inhibits insulin degradation because it changes the pH of lysosomes, because of which the intracellular insulin is not degraded at that space. Apart from that, obviously there is reduction of inflammation because it has got anti-inflammatory properties and which ultimately will result in improvement of beta cell and insulin resistance. Now this is a study which has been published in Diabetologia. Now Diabetology is one of the very reputed journals. Anti-diabetogenic effect of hydroxychloroquine on insulin sensitivity and beta cell function. And what this study has shown that HCQ improves both beta cell function and insulin sensitivity in this group of patients. Apart from that, I have shown you that adiponectin levels are low in patients of diabetes. With use of hydroxychloroquine, when you are decreasing inflammation, levels of adiponectin increases, which is a beneficial aspect in patients of diabetes. And then again, this is a proof of concept study done in mice models. If you see, this is a diabetic, and to that diabetic, to one model, we have given placebo. To the other, hydroxychloroquine is given. And then fluorescent staining is done for beta cell and alpha cell. Just have a visual impression. This is the fluorescent staining in a diabetic mice who is given placebo vehicle. And this is with HCQ treated. See the change in glucagon. We have now lots of lectures on hyperglucagonemia, which is a big problem in diabetes. So the staining for glucagon goes down. So definitely we have mice model evidences that giving hydroxychloroquine is going to bring about changes even at the level of beta cell and alpha cell. Now this is phase 4 study. This drug is launched in India. Drug is to be used for management of type 2 diabetes if your patient glucose levels are not in control on sulfonylurea and metformin. This is a standard approved indication by DCGI. Now after launch of the drug has undergone a phase 4 study where they have collected the data for improvement in glucose level, HbA1c, improvement in HSCRP, and in this phase 4 study, it has been shown there is a significant decline in HbA1c to the tune of 1.1%. There is improvement in fasting plasma postprandial, and significant reduction in inflammatory markers are seen, especially in a group where HSCRP at baseline is more than 3. So beneficial improvement is seen in number of glucose parameters, including HSCRP. This is the only drug which results in improvement of inflammation. Friends, unfortunately, nowadays we learn what pharmaceutical wants to learn. If we go back and search the literature, even metformin is associated, the beneficial effect of metformin is partly because of decrease in inflammation, which metformin brings about. But it is not that powerful. Sulfonylurea does not have any anti-inflammatory effect. There are some information, initial information, that GLP-1 receptor agonist might be having even anti-inflammatory properties. So this is actually a problem which has been addressed indirectly by some of the other drugs which we are using directly. But HCQ is a drug which is directly addressing the problem of inflammation as a problem in diabetes and pre-diabetes or obesity. So currently, most pharmacological approaches for management of hyperglycemia in diabetes aims at improving insulin secretion and insulin signaling without tackling the inherent cause of these disease, which is activation of innate systemic immunity. Some of the anti-diabetic drugs, as I have told you, metformin, glitazone, GLP-1, they have some effect on reducing inflammation. Inflammatory mediators are involved in reducing insulin resistance as well as insulin secretion. We have now having improved understanding of these pathways, which may help us in predicting, preventing, and doing effective treatment of diabetes. Although there are limited number of clinical trials with anti-inflammatory agents, which I have touched upon very briefly because of the time allotted, and except few, most of the results are not encouraging because of the side effects which are seen when we are trying to reduce inflammation systematically, and it will result in undesired side effects. Hydroxychloroquine is one drug which has been studied, found to be safe. There are some concerns about retina and others which we can address in question and answer, but largely it is found to be effective for management of diabetes. But what is important is it is need of the hour to explore purely the potential of anti-inflammatory agents in management of type 2 diabetes. And it is we, Indians, where this drug is available and is approved for management of diabetes, where we have to generate our own data, we have to build up our own confidence. This drug is not available in Europe or America, so we cannot look back at Europe and America, where they are providing us with all the data and then we start believing a drug. So here the situation is reverse. This drug is developed in our country by our own company, one of the Indian companies. So we have to develop our own data so that we can develop our confidence that yes, this drug is going to be effective for management of type 2 diabetes. To conclude with, fresh thinking rather than predetermined or predictable thinking is required. Sometimes we sit in the lecture with a predetermined and thinking कि मेरे को तो यही बोलना है, यही सोचना है, which is actually a bad, because practicing medicine is an art of interpretation of science, and whatever we are interpreting, then applying it to the alteration of human behavior, health and disease. Thank you very much.
Thank you, sir, for that excellent talk. We'll have the discussion after.